Ladies and gentlemen, dear colleagues, it's a pleasure today. I'm sorry for my voice. It is the flu. It's my pleasure today to have another European Society of Gynecology webinar on a topic of very, very great importance, the deep vein thrombosis risk, which is a part of our daily work, daily activity. But we have today two masters. We have Professor Jonathan Douxfils, who will speak about the normalized activated protein C sensitivity ratio, the INR of the gynecologist for a safer prescription of estrogen-containing products, and Professor Nathalie Chabbert-Buffet on DVT in contraception. I will start with Professor Jonathan Douxfils and then later on with Nathalie, and we will have the general discussion at the end. Jonathan is a globally recognized expert in thrombosis and pharmacovigilance with extensive experience in studying thrombotic events linked to hormonal treatment, including combined oral contraception. He holds a PhD in biomedical and pharmaceutical science, and this is currently a professor at the University of Namur in Belgium, where he leads a research unit in clinical pharmacology and toxicology. And you have, Jonathan, the microphone. You can share your screen, and then you can start your presentation.
Thank you very much, Andrea. Okay, so I hope everything is okay and that you can see the screen. Okay. Okay, so thank you very much, and it's my pleasure today to be here to discuss about a test that we developed several years ago, and the test is the ETP-based APC resistance. So it's a global coagulation test, but at the end, what is the more important is that the results are provided in a new unit, which is the normalized activated protein C sensitivity ratio, so the NAPSR. And I really like to make the parallel with the INR that we have in the cardiovascular field, because I think that in a few years, and I'm pretty sure of that the NAPCSR could be the INR of the gynecologist for a safer prescription of estrogen-containing products. Okay, so I was able to extract some very interesting data coming from the registries in Belgium. So in Belgium, approximately 5 years ago, we had more than 2.5 million women aged from 14 to 49 years of age. And among them, 60% are using a contraceptive method. And more interestingly, approximately 50% of these 60% are using the pill. So it means that approximately 30% of the women aged between 14 and 49 are using the pill. And considering the incidence that we have in Belgium and in Europe in general with the combined oral contraceptive, it's very, very interesting to know that for Belgium only, there is more than 750 thromboses that occur and that are linked to combined oral contraceptive use per year. I think if we are speaking not only about Belgium, but if we have a broader view and if we look at the European data, it may represent more than 22,000 cases of VTE which are related to the use of combined oral contraceptive each year. So I think it's an important global burden in developed countries. If we are just considering data coming from the World Thrombosis Day, if we speak about the US data, in US, the estimated number of VTE associated with combined oral contraceptive, we can think that we have approximately 16,500 VTE cases due to the use of combined oral contraceptive. And if we are considering the total annual expenditure of all VTE-related healthcare, this is approximately 10 billion per year. And so this is also interesting to know that the average 3-year societal cost attributable to VTE is around 40,000 euros. It came from data. It came from data that were extracted in 2016. So it means that today, considering the inflation, we are approximately 45,000 euros for a VTE. So it's also important to consider that this risk could even be higher in the younger population due to indirect costs and the long-term morbidity of thrombotic events. So I really think that there is an unmet yet medical need and societal need to reduce the risk of VTE associated with combined oral contraceptive. If the risk occurs, it's mainly due to the fact that, and the idea here is not to represent you a summary of the coagulation cascade, but it's due to the fact that combined oral contraceptive, and especially those that are containing 18 estradiol, are increasing a lot of procoagulant factor, and they are decreasing a series of anticoagulant factors, shifting the woman to a prothrombotic state. And we know that the prothrombotic state is even more important if we increase the dose of 18 estradiol, and if we reduce the dose, if we reduce the androgenicity, if we reduce the androgenicity of the associated progestin. So this is not new, but in the game now we have two different, I would say, players with estradiol and estetrol, and these pills that are containing estradiol and estetrol may have a totally different profile for the risk of VTE. Why? It's just because the thrombotic risk depends on the potency and the dose of the estrogenic compound, and especially up to now, we only had data with 18 estradiol containing products. We have some post-authorization safety study for estradiol containing product, but for estetrol, up to now, it's not yet the case. The only thing is that we have published some very new data regarding data coming from the ultravigilance database, and this will be presented also by my collaborator Nathalie just after this first presentation. And importantly, the thrombotic risk is then modulated by the androgenic activity of the associated progestin, with levonorgestrel being the progestin, I would say, the more capable to reduce the thrombotic risk induced by 18 estradiol. So to determine the relative risk of thrombosis, epidemiological data will be needed, and we will have to wait for another 7 to 10 years before being able to get to obtain the data with E4, and because we already have the data for E2 containing product. And the idea, the very first idea was to set up a blood test that would make it possible to quickly provide information on the potential thrombotic risk of a birth control pill. And this blood test should be able to identify both the inherited but also the acquired coagulopathies. Why? Because, for example, if you are taking the pill, you can increase the risk of VTE by 2 to 5-fold, but there is also other factors, and we should be able also to capture these factors. Obviously, some of them will not be able to be really captured because they are very acute, for example, being ill, or, for example, taking a flight. We know that this risk can increase the burden of VTE. But, for example, if you have an association of a pill with a genetic profile which is linked to thrombophilia, obviously you increase your baseline risk, and at the end, for example, being ill may then trigger the thrombotic event. So the idea is really to avoid this situation and to be able to identify both women which are high responder to the estrogenic component, but also being able to screen for genetic factors before putting a lady on combined oral contraceptive. It's especially important because if you are looking at the summary of product characteristics of all of these compounds, you have in the section 4.3 the contraindication, which are clearly claiming that a known hereditary or any acquired predisposition for venous thromboembolism, such as APC resistance, including factor V laden, antithrombin deficiency, protein C, and proteinase deficiencies, may be a contraindication for combined oral contraceptive. So the idea is really to question, how can we know it if we do not test it? And I will think that a lot of guidance are against the screening, because they are claiming that there is a low prevalence of genetic predisposition for VTE in the total population. But if we are considering just factor V laden and prothrombin mutation, for example, we already have approximately 7% of the population which is at an increased risk of VTE and which are normally contraindicated for combined oral contraceptive. So I really think that it is important to be able to screen, but we need to be cost effective. And the main issue is that up to now, we were not cost effective due to the fact that a complete thrombophilia screening is too expensive. It's around 500 euros to do a complete thrombophilia screening. And the idea was really to develop a test which is able to be sensitive to the estrogenic response at the individual level, but also being able to screen for predisposition of venous thromboembolism, such as factor V Leiden, antithrombin deficiency, and also deficiencies in other anticoagulant proteins. So how can we prevent this? It's really by providing a screening tool. The screening tool here is really focusing on APC resistance, which is the main driver of the risk of VTE associated with combined oral contraceptive. And at the end, the idea was really to use a test, which is also requested by the European Medicine Agency for the investigation that has to be done during the development of a combined oral contraceptive. The test is the endogenous thrombin potential-based activated protein C resistance assay. So this is something which is recommended by the European Medicine Agency, and the idea was really to use the basis of this test in order to provide you with a very easy scale from 0 to 10 in order to be able to to be sensitive to the estrogenic response and also any acquired, any inherited coagulopathies at the individual level. So importantly, I'm just using the pointer. Importantly, all results that are coming from the ETP-based APC resistance are expressed in normalized activated protein C sensitivity ratio. The idea is really to use a unit which is very easy to use. Normally, it's the results are provided from 0 to 10. The highest number, the higher the risk of VTE. And what we did is that we especially screen for any for the NAP-CSR depending on different combined oral contraceptive. And importantly, we were able to match the mean NAP-CSR with a thrombotic risk extracted from epidemiological data. And we did it for Noranel 20, 30, Desert 20, Desert 30, and Diane 35 at the very beginning. What we were able to design is a first model, which was quite interesting because we saw that there is a correlation between the NAP-CSR and the relative risk of VTE extracted from epidemiological studies, and the model was already quite confident in its capacity to to predict a potential risk for a potential pill. And so we reiterate this analysis by screening more and more combined oral contraceptive. We started obviously with women without the pill. So we can see here, this is a thrombin generation curve. This is just to demonstrate that you have here, for example, a normal curve, and you have the condition which is sensitive to the presence of activated protein C. So you can see that when you add activated protein C in your test cupule, you have a reduction of the procoagulant state. So this is normal. This is the normal population. And this is what we can obtain, for example, with 18-estradiol 20 with levonorgestrel. So obviously we have an increase in all procoagulant factors, and we can see a decrease in the anticoagulant factors because we can see that this curve is more important than the one in the normal population. So it provides us with an NAP-CSR around 3.5. We did the same with 18-estradiol 30, levonorgestrel 150, with 18-estradiol 20, desogestrel 150. And here again, we can see the huge increase in the procoagulant factors and the huge increase in the fact that the anticoagulant factors are decreased. So this is this is translated into a higher NAP-CSR. And here, for example, for 18-estradiol 20, desogestrel 150, we have a mean NAP-CSR of 4.5. It is even more important for 18-estradiol 30, desogestrel 150. So we have here a huge increase in the procoagulant phase, and we can see that we are not able to provide a good anticoagulation as well due to the decrease in the anticoagulant factors. And this is translated in an even higher NAPCSR. So here it was around 5.4 in terms of NAPCSR. And we did the same for 18 estradiol 35 ciproterone acetate 2 milligram, which is also quite well correlated with the epidemiological data. And interestingly, we then tried to know whether with this model we are able to predict the risk with combined oral contraceptive, which were not initially in the model. And for example, we did this for 18 estradiol 30 dianogest 2 milligram, for estradiol 1.5, normegestrol acetate 2.5, and with E40 RSP. And interestingly, what we were able to link with is that based on the data coming from epidemiological studies and the meta-analysis of De Bastos, the idea was really to see whether the results obtained with independent observational studies like the PRO-E2 and the INASCO study were able to fit with the prediction that we obtained with the model for these combined oral contraceptive. And here we started with 18 estradiol 30 dianogest 2 milligrams. So we obtained a mean NAPCSR of 4.79, and the estimated thrombotic risk was 3.6. So the relative risk of VTE was 3.6 compared to non-user. And this is quite interesting because we reiterate obviously the same with E2 NOMAC. So for E2 NOMAC, we obtain a NAPCSR of 2.57, and the estimated thrombotic risk was 1.7. It was very, very interesting. And if we compare with the risk obtained in the literature, we were quite confident. For E2 NOMAC, the estimated risk was 1.68. The risk coming from the literature compared to non-user is 1.58, so we are very close. And for EE30 dianogest 2 milligram, the thrombotic risk from the model was 3.57, and the thrombotic risk from the literature was 3.42, and the confidence interval are very reassuring, because we can see that what we have obtained from the model is really what we have obtained also in the epidemiological data. So we were then able to perform just a correlation on the expected risk of VTE from the model and the observed VTE risk coming from the epidemiological data. And we can see that based on that, we were very, very confident with an R-square about 0.98 and a slope which is very close to 1. So this is really, really reassuring, because the model is really able to predict what we have obtained in epidemiological data. So if we focus on E40 RSP, for which obviously we don't have yet the result from the INAS-seq and the INAS-NES study, the mean NAPCSR was 2.30, and the estimated thrombotic risk is 1.5, which is very, very reassuring for this compound. And we know that E4 has a very low impact on the liver, which is totally consistent also with the mean NAPCSR observed in this model. So it is interesting because the NAPCSR is really the basis of this thrombosis prediction model for VTE risk with combined oral contraceptive. But on the other hand, I think there is also another possibility to use the NAPCSR in the daily practice, because here the idea was first to provide information on the potential risk of VTE with this different association, but, and this is more important, we were also able from the model to provide for each combined oral contraceptive which has been included in the model a reference interval for which we can consider that if a woman is within this interval, we are in line with the expected risk from epidemiological data. So it means that if you have, for example, NAPCSR between 2.9 and 4 for EE20 levonorgestrel 100, you have the expected risk coming from epidemiological data, which is around 2.3 compared to non-user. And this is the same for all different associations. So it provides a reference range for each combined oral contraceptive. If you are in the range, it means that you know the risk because it is the risk which is expected. On the other hand, you can be a high responder, and in that case, for example, if you are on 18 estradiol, 20 levonorgestrel 100, and if your NAPCSR is above 4.03, it means that you are probably an over responder to ethinyl estradiol, and it means that you can be switched, for example, to natural estrogen in order to ensure that you lower the risk in this individual patient. So we have provided a decision-making tool, especially for the center with which we are working, and this algorithm is quite easy to use, even if it looks complicated at the first sight. If you are using for the first time the pill, then you can perform an NAPCSR. If the result is above 3.2, it means that you have probably a thrombophilia. And in that case, you should be redirected to a progestin-only contraceptive. If it is not the case, you can use either a progestin-only contraceptive or a combined oral contraceptive based on the situation. If you are already on the pill, if you are already on a combined oral contraceptive, you can perform an NAPCSR. You check whether you are on the range, the reference range for your pill. For example, ethinyl estradiol 20, levonorgestrel 100, you should be between 2.9 and 4. If you are in the range, then okay, you can continue the treatment. If you are not on the range, or if you are above the range, you have to provide a 2-week washout. You retest your NAPCSR. So after 2 weeks, we can expect that the effect of the combined oral contraceptive on the coagulation is removed. And then when you will test after 2 weeks the NAPCSR again, you will be sensitive to the presence of any thrombophilia. If the result is above 3.2, it means that you have probably a thrombophilia. So in that case, you should be redirected towards a progestin-only contraceptive. If it is not the case, so if the result is below 3.2, it means that you are not suffering from a thrombophilia, but that you are a high responder to ethinyl estradiol. And in that case, you should be switched either to progestin-only pill or on natural estrogen because they have a different profile on the liver, and it means that you are probably over-responsive to the presence of ethinyl estradiol. So this is really reassuring because using this algorithm can really reduce the burden of VTE in combined oral contraceptive patients. And why am I claiming that? It's just because if you are analyzing the START registry, and this is a very interesting study from Elvira Grandin, for combined oral contraceptive associated VTE, what we were able to see in this registry is that 61% of the patient are suffering from a thrombophilia. So among 157 ladies with a combined oral contraceptive associated VTE, 61% of them are also suffering from a thrombophilia, while the family history of VTE is only present in 15% of them. So it means that we are probably missing 45% of the ladies with a thrombophilia, because if we know that we have a thrombophilia, you cannot be on a combined oral contraceptive. So it means that this is really this association between thrombophilia and combined oral contraceptive, which is an important driver of the risk of COC-associated VTE. So if we are able to detect that, not only factor V laden, as we are usually doing with conventional routine tests, the NAPCSR is not only able to address the resistance towards activated protein C, it's able to assess the resistance towards activated protein C, which is linked to factor V laden, so thrombophilia, but also the supra-additive effect of, for example, the combination with ethinyl estradiol containing product or any estradiol containing product or estetrol containing product. So this is really interesting because we are not only capturing the genetic risk, but also the acquired APC resistance and the supra-additive effect of both. For example, if here it's just a population in red, it is a population which are using combined hormonal contraceptive. And this is here a population with factor V laden plus the use of 18-estradiol, and we can see that there is an important supra-additive effect compared only to factor V laden patients. So this is interesting because you can check either the acquired APC resistance, but also the contribution of any genetic predisposition for activated protein C resistance. So how does it work? During the gynecologist consultation, and we have implemented this strategy in several centers in Belgium. The gynecologist is just prescribing the test, so it's really easy, it's just a blood test. The blood is then stored at -80 and it is shipped to our laboratory, and we are providing the results within 10 days. And then if the NAPCSR before prescribing the pill is above 3.2, but then the gynecologist knows that he or she has to put the woman on a progestin-only pill, or if it is outside the range, that he can switch or respect a washout period and then switch probably the woman to safer contraceptive like natural estrogen containing pill. So the aim of the NAPCSR is really to identify a prothrombotic tendency involving hormones. So it can be either combined oral contraceptive, but we are also collecting data on tamoxifen, hormonal replacement therapy, and even during the pregnancy. But to be fully efficient, this test should be integrated also in a prescription algorithm, which will take into account also other risk factors that are not covered by the test. For example, the BMI, the age, smokers, the blood group, or any family history. Because if we are combining all of these factors, we are really able to have an individual prescription of combined oral contraceptive, which may improve at the end the safety of the prescription. Importantly, the test will be able to stratify the thrombotic risk and then can serve as an eligibility testing for this hormonal therapy, and also to monitor the risk during pregnancy. This is another application that we are currently developing with the NAPCSR. So currently, with the center with which we are collaborating, the NAPCSR is proposed as a screening tool before and during a contraceptive therapy. Before, in order to assess the coagulable state of the patient and prescribe the appropriate contraceptive therapy by considering the NAPCSR in the benefit-risk balance, and also during or after 2 cycles at minimum to identify another response to the estrogen therapy. Mainly, it is 18-estradiol on the coagulation system, and then it could require a potential change in the contraceptive choice. So I thank you for your attention. I'm open to the discussion and also to your question, and I will be very happy also to discuss the data that will be shared and presented by Nathalie. Thank you very much.
Thank you, Jonathan. Thank you, Jonathan, for that passionate lecture. And now we will go to Professor Chabbert-Buffet. She is a globally recognized expert in thrombosis and, she's professor of endocrinology and reproductive medicine, coordinator of the fertility clinic and of the family planning center, involved in clinical practice, research, and teaching on hormonal control of the pituitary gonadal axis. Her age index is 44, and the citation 9,800. Compliments, Nathalie. You have the microphone.
Thank you, Andrea. I'm very happy to share with you some slides about DVT. I'm not sure you can see my slides. Okay, so I'm happy to share with you some slides about the DVT risk in contraception. And this is my COI. And so I'm going to discuss with you the case of Louise, who is 18, and she would like to initiate contraception, and she has no specific personal history, nothing bothering. She's never been pregnant. She's been having a normal puberty with menarche at 12, and menses are now regular and quite normal. She's not overweight, and her blood pressure is normal. But when you get to the family history, she says that her mother, when she was 32, had a problem in the chest, and we cannot be sure that it was not pulmonary embolism. And she doesn't have much information about this. And when you go to the risk factors, then she is a smoker, although it's not a very heavy smoker, but she does smoke 5 cigarettes per day. And we don't know anything about other risk factors since she never had any blood test of any kind anytime. So, does Louise need to be tested for thrombophilia at this moment of the contraceptive consultation? So this has been commented a little bit by Jonathan, who has been trying not to kill you with all the details in this. And this question of the thrombophilia testing is something very, very complicated. Because as you see, there are many, many factors that can be tested. So if we want to test everything, as Jonathan said, it's going to be very expensive. And then the interpretation of the results themselves is quite complicated also. And it depends on the family history, the specific risk factors of the lady, and so on. So the recommendation has been commented before by Jonathan are, for example, for the British Society, is not to to predict a first episode of VTE, and they suggest to test specifically the first degree relatives of probants with some identified abnormalities. And at this stage of the story, we don't know anything about Louis' mother, so we're not going to test her. So she says, I have to start this contraception quite quickly. It's getting urgent for me. So what are you going to offer today to this young lady in order not to have her with any problem? So you're going to choose, of course, progestin-only contraceptives. And what are you going to choose? So the POPs are not related with any increase in DVT risk. This is the meta-analysis from Manta, like 10 or 12 years ago. So there is no significant increase in the risk of DVT. If you are considering a LARC for this young lady who may be in trouble with taking a pill every day, then you have two options. You can choose the LNG IUD because there is no increase in the risk, but you may not choose injectable high-dose progesterone like DMPA because it does increase the risk in a very important manner. It's as high as with the combined hormonal contraceptives. So 6 months later, she comes back, and finally the history of pulmonary embolism was not confirmed for her mother. She was wrong, it was not a PE. And she's been using your POP, but she's been spotting for 6 months, so it's a very long time with spotting, and she's really fed up with that. So she's not willing to use an IUD, so the next option would be combined hormonal contraceptive for her. And so what are the risks that are associated with this, the use of such contraceptives? Well, it's quite rare, by the way, because you see the highest risk is VTE, and it's almost 7 per 10,000 women year users. So it's not frequent, and the arterial complications are even much lower, 10 times lower. So this is not something frequent. However, we need to take that into consideration, and together with other risk factors, this has been said by Jonathan too, so if we insist on that, it's very important. So the contraceptives are associated to quite an increased risk, and we're going to see that in more details later, but they're not the only ones. And you see that trauma can be very high risk with thrombosis, and very interestingly, pregnancy is also at high risk of DVT. So the risk-benefit balance of using a contraceptive has to be, considered, taking into account all these, including the risk associated with the pregnancy. Is it very dangerous, and what is the risk of fatal events? Well, the fatal events can be 2 to 5%, and if you compare with other events in life, when a car accident can be fatal too. This is in Europe, and this is in the US because they drive slowly. And if we go to the to contraceptives, well, a young lady like Louise who would not smoke has almost no risk of having an accident, of dying from a DVT. Louise is here, she's smoking, so the risk is quite higher. You can see these are the reference publication by Trussell, although it's quite old, it's still a reference. And you can see here that the association of risk of death from any event is dependent on the use of contraception, the age you're having, and the situation in association with smoking or not smoking. And this is the risk of dying from being pregnant and giving birth, very high too, as you can see. So the history of VTE and contraception is a kind of part of history of medicine, and we've been learning a lot during time. And so this is the initial situation with these very high dose ethinyl estradiol contraceptives and very high impact on the risk of pulmonary embolism and VTE. They've been published quite shortly after the release of this first pill. Then, knowing that the EE could have a very important impact, the industry started lowering the doses of ethinyl estradiol, and this induced a decrease in the risk of VTE. Then we tried to improve the tolerance of the associations and try to modify the progestin, which is very androgenic in the initial combinations, and try to decrease the androgenicity of these compounds. And doing this in a kind of experimental manner, by the way, the VTE risk increased again. So the association, the progestin that is associated with the estrogen plays a very important role also in the risk. And this has been reported, and this is another very important reference in the field of Lidegaard from Denmark. And this is the relative risk compared to a non-users that is associated with different contraceptives, including ethinyl estradiol for all of them, with different progestins. And you can see that some of them are associated with an increase but not so much risk, and others are associated with a very much increased risk. And you can mention that I didn't say a number of generation, first, second, third generation. We have to quit that because although norgestimat, for example, is a member of the third generation, its risk is rather close to the one of levonorgestrel rather than the risk associated with the desogestrel or gestoden ethinyl estradiol combinations. Other important point is the non-oral route of these contraceptives with ethinyl estradiol do not reduce the risk of thrombosis. So if you have a contraindication to the oral route, then do not use any other route. To be known also the starter effect, the risk is higher during the first year. Then you would return to baseline approximately 2 months after discontinuation of the pill. Don't forget specific patient education in these those who will air travel. Jonathan has been saying that there are many other factors in addition to the pill that will contribute to increase the risk. So we really need to think about this education of our patients. This is a paper when they observed the first one in an astronaut woman. So can we mitigate the risk in these users of combined hormonal contraceptives? Well, we know that the impact of ethinyl estradiol is much higher than that of estradiol, and you've seen that from the biological point of view with Jonathan. And we have these two associations with estradiol, more or less. They've been available for more than 10 years. Then we've been waiting for more than 10 years for the post-authorization safety studies that you know. And given the design of these studies, it was not possible to show any difference between these pills and those with ethinyl estradiol and levonorgestrel. So if you do a meta-analysis and you have just seen the first author of this paper recently published in Frontiers. If you do a meta-analysis of the data available, so this is for the NOMACI2 on the first line, and the second line is also a 2 studies pool data of estradiol, valerate, and dienogest. And you see that in the meta-analysis, because the numbers are higher, then you can reach significance. So with these associations, we know that the impact on thrombosis risk is lower than with ethinyl estradiol and levonorgestrel. So what is new now? What is new? The new thing is estetrol. What is estetrol? It's a very ancient estrogen that exists in every pregnant woman, which is produced by the fetal liver, and which has specific pharmacological characteristics, including the way it its effect is given to the cells. So usually estrogens act in the nucleus and at the membrane. And the membrane system, which is called MIS, is a very rapid system of transducing the effect of estrogens, and it is involved in what happens in the liver, including coagulation factors. And the specificity of estetrol is that it does not impact this part of the effect of estrogens. It has only slow genomic effects in the nucleus. So we could already expect that the impact of this molecule on the clotting factors would be lower. So this, in addition, is associated with drospirenone, which is a long half-life progestin with a high efficacy in contraception, as you know, probably. And so what do we have as a clinical experience in the real life in Europe? Well, this is the time to let Jonathan, who is the one who has been doing the job, comment these slides if he may come in. Thank you.
Okay, thank you very much. So this is the data that we extracted from the European Pharmacovigilance database. The name of this database is EudraVigilance. And what we did is that we analyzed the ratio of, so the reporting ratio of thrombotic events among all other adverse events that had been reported for each combined oral contraceptive. And what we can see it is that if we are considering 18-estradiol as the 18-estradiol levonorgestrel as the reference, what is really interesting is that you can see that with third generation COC, for example, desogestrel or even 18-estradiol drospirenone, we have a higher proportion of these adverse events which are related to venous thromboembolism. So it means that the reporting ratio is disproportional compared to 18-estradiol levonorgestrel, and so we can consider that 18-estradiol levonorgestrel is quite safer than 18-estradiol desogestrel. But quite interestingly, when we look at the data of natural estrogen, for example, E2 Dynogest and E2 Nomac, we can see that we have a lower reporting rate of venous thromboembolism compared to 18-estradiol levonorgestrel. And it's even more important for E4-DRSP. And by the meantime, we also decided to extract the data from the EudraVigilance database for a product that has been marketed at the same time as E4-DRSP, so DRSP alone at the dose of 4 milligrams. And what is interesting it is that the reporting rate of thrombotic event for E4-DRSP and DRSP alone is quite the same. So we are totally in line with the biological data that we had and that we have for E4-DRSP. This is also in line with the observation that natural estrogen, including estradiol and estetrol, are have less effect on the liver and on hemostasis compared to 18-estradiol containing product. This is totally in line, and it's also in line with the observational studies. For example, for E2 Dynogest and E2 Nomac, the data coming from the EudraVigilance database are really in line with the Pro-E2 and the INASCO study. So this is really reassuring because these data are publicly available, so we can analyze it when we want. And on the other hand, it's also in line with the results. It's also in line with the results we obtain. Sorry, I can see that I have sometimes a problem with my
camera.
Yeah, with my camera. I don't know why my iPhone is always connecting on this. Okay, can you see me? And all the data are in line with what we have observed in observational studies and in biological investigation, because we also demonstrated that natural estrogen has less effect on the liver compared to 18-estradiol containing products. So this is really interesting to see that.
Yes, and if you go further on the right side of the graph, then you can see that the ratio between these contraceptives and the EE levonorgestrel, for example, is about 2 to 3, which should remind you of the numbers I've been showing you in the Danish study. It's exactly the same. So
exactly the same pattern.
Yeah, because you could say, well, it's just reporting, so we don't know how many women have been exposed and so on. But what is very reassuring is that this is what we used to see in other approaches. So I think this is a very important result. And I've heard that we're going to get data from the USA some month.
Yeah, so currently we are also doing the same extraction from the FIS database at the US level, and regarding the reporting rate for E4 DRSP, EE DRSP, and EE DSG, we are in the same range as what we have observed here. So we are confirming the result that we obtain with the drug vigilance database in the US FIRS database. So this is also very reassuring, because all the evidence is pointing into the same direction, that switching from ethinyl estradiol and synthetic estrogen to natural estrogen will improve the safety of combined oral contraceptive regarding the risk of VTE.
Thank you very much. So finally, so I can't move. I can go to the next one here. So as a conclusion, the VTE in contraception, so the events are rare, but we have to be careful, of course, because sometimes exceptionally they can be fatal. There is no additional risk with progestins only, except for MPA. The risk-benefit balance is to be considered, and pregnancy is more dangerous than combined hormonal contraceptives in low-risk women. And furthermore, if you use natural estrogens, of course. And the secondary benefits of contraceptions are many of them, including pain in endometriosis and so on. So we really have to use this risk-benefit balance, explain it to the patients who are sometimes not willing to use hormones, and that is a pity because there are many benefits to this. The screening for thrombophilia is not a routine test before the pill, and maybe we may use the Jonathan Douxfils test in the future, rather than spending a lot of money trying to find mutations in many different clotting factors. And then we have to be very careful with association of risk factors in the women, and educate them on control of their BMI, be careful when they have to take a plane and so on. And the choice, to end with that, the choice of the contraceptive combination is really a possibility to greatly reduce the risk of thromboembolism. So I wanted to thank you very much for your attention, and you're very welcome to come and visit Notre Dame, which has been just reopened.
Thank you, Nathalie. I'm sorry for my voice. It was a fantastic webinar with both are discussing at the same point. We have received a series of questions. Jonathan, one for you. How does the APC test improve our understanding of thrombotic risk compared to traditional methods of assessing APC resistance?
Yeah, so I briefly mentioned that in the presentation. So normally when you are screening and not assessing the genetic risk, but just a screening test for factor V laden, the only thing that you're able to see is the mutation in the factor V. So you cannot see the acquired APC resistance, which is due to the presence of the combined oral contraceptive. So the NAPCSI is really able to capture both the inherited and the acquired APC resistance and the supradditive effect of both, which is quite interesting, especially in women who are already on combined oral contraceptive.
Thank you. And then, Nathalie, a question for you from Svetlana Mavrodi. She asked, my question for Dr. Nathalie is whether it is necessary to cancel the COC before a planned surgical operation.
Well, it depends on the contraception, but if she's using a high risk contraceptive, including the levonorgestrel ethinyl estradiol, then if it's not an emergency contraception, we would prefer to stop it some weeks, at least I would say 1 month before the surgery. If it's an emergency, then you just stop on the same day and that's it.
Thank you. And Jonathan, for you, considering the findings from your meta-analysis and pharmacovigilance data, what are the implications for prescribing practices, particularly which natural estrogen like estetrol?
Mm-hmm. Yeah, I think it's a very interesting question, but in my opinion, we clearly need to revise the guidance. Up to now, we are still considering ethinylestradiol levonorgestrel as the safest combined oral contraceptive regarding the risk of VTE, but it's no longer true if we are considering the evidence. The evidence is coming from both observational pharmacovigilance database, but also biological data. So all this information are pointing into the same direction, and they demonstrate that natural estrogen like estradiol and estetrol containing pill are clearly safer. So the pharmacovigilance database is really, I would say, the cherry on the cake to prove that natural estrogen are safer than ethinylestradiol containing pills.
Thank you. And Nathalie, for you, can we detect high-risk women?
Well, it's very difficult today, and what we heard from Jonathan, I think, is a really a trail to be used to detect these women, because the test will allow us to with or without the use of contraceptives, by the way. I think even before they start, then you can have an idea of where the woman is as compared to the reference values. And if she's above 3.2, you said, I think, in this test, then it means that she is at higher risk. So you can have an idea of the contraceptive to offer with this test without having to do all the genetic testing. The other way to do is if it's evident that a woman with a mother who had a very early pulmonary embolism in a situation of exposure to estrogens, like postpartum, for example, this patient is not a good user of combined hormonal contraceptives. You will have problems probably. So the biology is important, but also the personal and family history that we have to take both into account.
Thank you. And Ardell Piper, she asked, drospirenol and VT risk is higher when solo progestin are compared. Please explain again why in combo with estetrol the overall VT risk is significantly lower.
I'm not sure. I didn't get the question. I'm sorry.
Yes, is drospirenol and VT risk is higher when solo progestin are compared. Please explain again why in combo, when we have both of them together, with estetrol, the overall VT risk is significantly lower?
Well, it's lower than with a combination with ethinylestradiol, but it's because it's not increased. It's at the same level as drospirenol alone.
Yep.
The basal risk, and there is no increase in the risk of. It's not lower. It's just not increased.
Thank you.
So for the RSP alone, as it is a progestin-only pill, they don't have also to run a post-authorization safety study. So they are considered by the European Medicine Agency in the same basket as desogestrel alone. So they are considered as having no risk. But if we are considering the data with ethinylestradiol in association with drospirenol, I don't think this is a good combination, because drospirenol is not able to counterbalance the hemostatic impact of ethinylestradiol. But the combination with estetrol is totally different, because estetrol does not have an impact on the liver, so there is nothing to counterbalance. And then it is a possibility to have this association of drospirenol with an estrogen. It is only because we are using estetrol and because estetrol does not have an impact on the liver. And I think it is an important point to consider. But DRSP at the dose of 4 milligrams will share the same risk, in my opinion, and this is observed also in the drug vigilance database, will share the same risk as E4 DRSP.
Absolutely, absolutely. I totally agree with you. Then now, Nathalie, for you, it is possible to prescribe COCHC, combined contraceptive, after a thrombotic event?
Well, normally not. It can be discussed. You have to do the tests, the one of Jonathan, genetics maybe, and so on. And then you have to think about what was the circumstances of this DVT. So if there was an evident risk factor, like she had a major car accident and she was, blocked in her bed and could not move at all for weeks, then it may be rediscussed. But I would propose first a progestin-only pill or an IUD. And in case you really does not tolerate any of those options, and in case the VTE was due to something very specific and not estrogen dependent, and in case she doesn't have other risk factors, then I could try and reintroduce a CHC if necessary, and I would probably choose one with natural estrogens or estetrol.
Yes, and then like another question. Now we are in the winter time,
Yes.
Nathalie, and then the people go skiing. And when
Yes.
we go skiing, I will go also. Sometimes we crash. And if we crash, we broken our legs. And if she's taking a pill during the time, you suggest that she stop the pill?
Yes, I would suggest she switches to a POP for the duration of the immobilization.
Perfect.
At least.
Very important. And then now we are at the end. Jonathan, a question which is fundamental to better understand also what authorities are doing. You mentioned the potential integration on the APC test into a prescription algorithm. What challenges or barriers do you foresee in implementing this tool into routine clinical practice? This is you have to convince our legislator.
Yeah, I think an important point first is to be able to obtain the European Commission approval of this, and this is the reason why my company is currently working also with a big manufacturer. A big manufacturer at the European level and also in the world, in order to get the approval from the European Commission to spread the test into routine lab. But I really think that then the price will be key. And we saw it with the current strategy for thrombophilia screening. It's too expensive and it's not cost effective. I was speaking about approximately 40,000 euro for VTE, 22,000 VTE per year. So it can represent a burden of approximately 900 million euros per year in Europe. If we want to implement a screening strategy, we have to be cost effective. So we need to be able to demonstrate that we can reduce the risk of VTE by approximately 50%. And this is exactly what we have observed in the START registry. If we consider the number of women suffering from thrombophilia in this registry, it means that approximately 50% of them will have a wrong prescription of a COC because they have a thrombophilia. So we need to be able to detect the thrombophilia at least by 50%, in order to be sure that we will not prescribe a combined oral contraceptive. So we will be able to reduce the burden of VTE at the European level by approximately 50%. So it means that we can spare 450 million euro a year. And so the strategy for screening the 4.5 million ladies which are put on COC at the European level each year should be below this price. So it means that we cannot spend 500 euros for that, but something around 50 to 70 euro per test. And if we are able to do that, then we are cost effective. And if we are cost effective, then we can implement this into the routine.
Thank you, Jonathan, for your hopes. And then probably are also associated to your younger age. At my age, we have some concern with what the authorities are understanding, first of all. Then, thank you. I would like to have a final comment for a clinical point of view, which is of fundamental importance because contraception is something which is used and then is promoted also to reduce unwanted pregnancies and to protect the women's health. And then I would like first your comment, Nathalie, and then after the comment of Jonathan. At the end, the take-home message.
Take-home message is try to reassure women that hormones are very efficient, but not so dangerous contraception, given that we prescribe it in the rules. So we have to promote that and promote the new associations that are really going to be able to improve women's health globally.
Thank you. Jonathan?
I think that now we have a lot of technologies and new pills which are safer, and we really need to rethink the guidelines in the coming years, taking into consideration the latest evidence, especially concerning natural estrogen and the possibility to use a screening test in order to improve the safety. I think it's really important in the coming years to do that.
Yes, it's also very important that the authorities, they evaluate what are the results related to ethinylestradiol use. Ethinylestradiol was a need when we started 40 years ago, but now I think we have to try to go on to thanks ethinylestradiol and to go on to more safer molecule. Dear friends, thank you very much. I'm sorry for my voice. But we have enjoyed that duo fantastic. And then thank you also for having shown us the beautifulness of Notre Dame that we have seen in the television, and we hope to visit you soon in Paris. Thank you very much. And I would like to invite to the next webinar, which will be the 15th of January at 3 o'clock, Tailoring Endometrial Cancer Prevention and Treatment in Current Medical Practice, with Professor Andrea Giannini and Professor Francesco Multino. I invite all of you of coming. It will be a very attractive and stimulating talk as it was today. Thank you, dear friends. And then I invite you to come to Riga to the Congress of the European Society of Gynecology next March. Thank you again. Merci beaucoup.
Thank you, Nathalie. Thank you, Andrea.
Thank you.
A real pleasure. Merci.
A great pleasure. Thank you.